When we say respiratory distress, we're really referring to the use of compensatory mechanisms to maintain adequate oxygenation and ventilation when something, one of many things, is causing respiratory compromise. Typically, the compensation consists of an increase in the rate and work of breathing. That increase will increase minute ventilation, allowing the child to exhale more carbon dioxide when gas exchange is impaired. Signs of respiratory distress include retractions, sternal retractions, for instance, because of the flexible, compliant breastbone, as well as intercostal retractions. And this is an example of increased effort resulting in muscles exaggerating the spaces between the ribs or in the sternum. Use of accessory muscles, such as the strap muscles in the neck, nasal flaring, and grunting, an expiratory noise that's designed to apply some PEEP. Children in respiratory distress typically are anxious. This is an uncomfortable feeling, and with that stress, they oftentimes have tachycardia. These are some examples as well of signs of respiratory distress. The child who wants to sit upright and is unable to lie flat comfortably. The child in the left looks anxious, and the child in the right is demonstrating increased work of breathing. Respiratory failure, on the other hand, is at the other end of the spectrum and is defined by inadequate oxygenation and ventilation. Essentially occurs when compensatory mechanisms fail to maintain gas exchange. Interestingly, respiratory failure can occur without preceding respiratory distress, meaning it can happen when there is depression of respiratory effort, typically by something like a poisoning, which depresses mental status, or seizures, or severe weakness, leading to inadequate respiratory effort. Signs of respiratory failure when the compensatory mechanisms are no longer able to sustain gas exchange include desaturation or cyanosis despite supplemental oxygen, the appearance of increased effort leading to poor air entry. In other words, lots of work for very little gain. This may be characterized by a sound of gasping when the child inspires, head bobbing, which is an exaggerated form of accessory muscle use in which the head literally will bob as the muscles of the neck and shoulders are trying to participate in gas exchange. Seesaw or paradoxical respirations, where the abdomen and chest move in the opposite ways than they usually do. And sounds of severe obstruction, such as stridor. The hallmark of respiratory failure, to distinguish it from respiratory distress, is a change in mental status. When oxygen levels fall and carbon dioxide rises, this is a very stressful feeling and results in sympathetic stimulation and agitation. As carbon dioxide continues to rise, it has a sedating effect on the central nervous system, leading to a child who's lethargic, sleepy, or obtunded. The child who appears to have increased work of breathing, desaturation, and sleepiness or obtundation is one in whom you need to be very concerned has transitioned from respiratory distress to respiratory failure and may progress to respiratory arrest and cardiac arrest. If left untreated, respiratory failure will progress to cardiorespiratory failure, meaning although it is primarily a problem of ventilation and oxygenation, having hypoxia and having acidosis from poor ventilation will depress the heart and result in cardiac failure as well. Signs of cardiorespiratory failure include a decrease in respiratory effort, cyanosis, bradycardia, and unresponsiveness. This is clearly a pre-arrest state and one that may only last for seconds to minutes before the child suffers a cardiac arrest.